Hello everyone, my name is Dr. Arvind Vatkar. I'm a consultant spine surgeon working at Fortis Hospital, Vashi. Today we'll be discussing a case of spinopelvic dissociation in which we did a lumbar iliac fixation. So what is spinopelvic dissociation? Basically, it is a bilateral fracture or longitudinally of the sacrum and also a transverse fracture of the sacrum, which was first described by Roy Camilli. And this kind of fractures have a high risk of cauda equina syndrome and lumbosacral plexus injury. Now, the case what we are describing over here, he is a 35-year-old male, had a road traffic accident and had got a tibial compound type 3B fracture with spinopelvic dissociation. In terms of the examination, the lower limb neurology was normal except the anal tone was absent and the anal sensations were also absent. The patient was already catheterized when the spine surgeon saw it. This is a case of one of my colleague, Dr. Akhil Tawri, who is also a consultant spine surgeon working with us in Mumbai region. So the catheter tug was also present in this patient. In terms of the CT scan, you can see there is simple focal kyphosis of the upper sacral segments like type 1, and there is no displacement. So this is kind of Roy Camilli type 1 based on the CT scan. And on the axial images, you can see there is a fracture of both the sides of sacral ala. Hence this is kind of type B fracture based on AO types. Okay, on MRI you can see he has got an L1 fracture which is stable, and he has got this fracture in the sacrum which is a part of the spinopelvic dissociation. On axial scans you can see there is a huge hematoma down in the sacral segments which is causing the compression of the sacral nerves. Now, in terms of the management, based on ATLS protocol, his ABC was managed and it was stable. The tibia fracture was fixed with a gastrocnemius flap. For spine issues, the patient had a highly unstable fracture and a comminuted sacral bone. The fracture and the hematoma itself was causing compression of the sacral nerves and causing cauda equina like compression. The patient was not amenable to S2 alar screws, which would have been more stable as the S2 was fractured. Hence, we planned for iliac screws and lumbar fixation. Now, the tips for iliac screw fixation based on freehand anatomical guidelines is that you identify the lamina of L5 and you identify the spinous process. Your Lenke probe has to be parallel to the lamina, upper end of the lamina of the L5, and has to be above the spinous process. And from here you start from the posterior superior iliac spine and target your Lenke probe towards the anterior superior iliac spine. This is how it looks in the real image. Okay, and on X-ray what you do is you do a 25 degrees coronal and 25 degrees sagittal plane angulation, and then you will see the iliac density over here through which the screw or the Lenke probe has to pass. So based on the similar guidelines, we fixed the we put the L4 and L5 pedicle screws. Additionally, we put the iliac screws, which were pretty good, about 70-80 millimeter screws, thick screws, and which were connected through side rods. And the decompression of the dural sac was done at the S2 level. This was the case we wanted to discuss.